number of speakers, as far as I could figure out, mentioned gene therapy, and I think that is what I'd like to introduce you to and give you some of the examples of the work that we've been doing. I don't have to explain this slide to you. I mean, you talk about epilepsy a lot and cognitive changes. So the only thing I'd like to mention to you, obviously, is that with the work that I'll present to you, what we're trying to do is to affect the brain circuitry using gene therapy. And clearly, some of the tools that we've developed over the years allow us to really modulate this in the genetic disorders, but not only, also the neurodegenerative disorders as well. I think one of those examples would be what's shown here, which is called the deep brain stimulation, in which the local source of energy is being applied to a specific part of the brain, in this case subthalamic nucleus. In Parkinsonian patients, you can really affect tremor or other aspects of the disease. But I'd like to use this slide to illustrate to you that the blood-brain barrier has been a huge issue for a number of, I think, exciting therapies that could be used in neuro-oncology, but also in neurodegeneration. So that is one of the issues that we clearly had to deal with. Won't spend any time talking about the gene therapy. I think it's suffice to say that there's a number of different ways of doing it. This is called the in vivo gene therapy, in which we would take the part of the genomic material, in this case cDNA, is incorporated into a viral particle. In this case, these are adeno-associated viral vectors. And there's a long list of these particles, different vectors, and different biology that it's critically important. And we've learned this over a couple of decades in terms of how to really utilize these systems for either expressing genes or for suppressing them, as it is a case, for example, in Huntington's disease. So here you have the current clinical trials in the CNS space. There are 43 trials ongoing right now with 16 disease targets. So they are listed here, so I won't be reading them to you. There are different vectors being used in terms of AAV alone. I mean, there are in addition to this, there are some other particles, for example, based on the lentivirus, which are being utilized as well. What's also critically important is how the viral vectors and gene therapy is being administered to the brain. So this in itself, I think, is a huge issue, as we've learned over the years, in terms of trying to really control the delivery strategy. And then there are different also doses being given. Suffice to say that we've been favoring the intraparenchymal administration because that seems to avoid a lot of immune responses, but also can be really precisely targeted into the brain circuitry as well. There are intravenous, intracisternal, intrathecal routes as well. So I will talk to you today about a monogenic disease called the AADC deficiency. This is what we've been working on for quite some time. I'll show you the results of the clinical trial, but also if time permits, then I'll speak to you about our ongoing 2 trials in Parkinson's disease. I've been in this field for several decades right now. I started with some of the work in the stem cells and fetal transplants in the 80s. And one thing I've learned over the years is that the delivery is the key to really being able to achieve your clinical goal. It is no doubt in my mind that has been dramatically underplayed over the years. And I think a lot of failures that we have witnessed, I think, had to do with the inability to really correctly deliver the therapeutic agent, whether it being the cell or gene therapy or recombinant proteins. So with that philosophy in mind, 2 things were very critical for us. One was to get a safe trajectory to the target in the brain. The other one being able to monitor the gene therapy delivery, just to fully understand that what we imagine and promise patient actually takes place. And you have to realize that a lot of this work has been developed in very small rodent brains, which really don't translate very well to the size of the human brain when it comes to that administration. So here's one of the examples of the system we've developed at UCSF for administration of gene therapy in the real time. In other words, what I'm going to be showing you from now on is the technology that had to be developed over the years to deliver gene therapy in the MR scanner under direct visualization. Not only of the target, so we really wanted to make sure that if we aim for some part of the brain, we really are there, so we had to confirm it during the operation, but also be able to get the monitoring of the gene delivery. So here's an example of the system. It's called the ClearPoint system. Here's one of the examples of the delivery of the gene therapy together with the MR tracer. This is gadolinium, so we mixed it together. We established and published over the years that wherever we see the tracer, that's where the gene expression is going to be. So I'm not going to elaborate on this, but it was very critical to establish a surrogate marker for this. And here you can see real-time infusion that we can actually keep adding more virus to really get a better coverage, or even be able to reposition the cannula to really get a better spread. You'll see this in a minute in patients. So here's one of the cases, one of the first cases actually done at UCSF, where you can see that the whole philosophy had to be changed in terms of being able to operate on the patient in the strong magnetic field. We're using 3T Tesla systems right now, so from being able to create a sterile field to using non-ferromagnetic instruments, and I think the whole safety protocols that had to be put in place, really a major challenge. We also had to develop the cannulas, a very specific special devices that are MR compatible, that would allow us to really get a good distribution. You have to imagine the brain is a little bit like, infusing into a matrix that just tries to squeeze things out, because you have intracranial pressure that actually prevents fluid that carries the viral particles from staying in the brain. It just tries to squeeze it out. So like pushing on the toothpaste, you'll get this thing up. It's called the reflux or the backflow. So these devices have been designed with this in mind, having a specific shape, specific steps, specific coding. I mean, all of this took a long time to really get it to develop, but resulted in us being able to use what we call the convection-enhanced delivery, which is the system that allows us to spread the fluid within the brain with nanoparticles through very large distances. So that had to be overcome as well. So here's an example of the ongoing clinical trial, and this is a monogenic disease. You can see one of those patients. They have a deficit in dopa decarboxylase. It's a enzyme I'll show in a minute that causes them not to have any dopamine and serotonin in the brain. They're profoundly hypotonic, never develop really. They develop hypokinesia. They are very dystonic. They have what's called the oculogyric crisis, which is very frequent for these kids and can be life-threatening as well. And they have tons of non-motor features. They're highly irritable. They don't sleep very well. They're very insomnic. They have autonomic dysfunction from temperature to sweating and everything in between, and profound intellectual disability. Almost exclusively every single one of those patients is nonverbal. And there's really not much treatment for these kids. Anti-Parkinsonian drugs being used, but this is highly symptomatic and doesn't really help in the management of the disease, and obviously would not increase any development. So very briefly, dopa decarboxylase, it's critical enzyme in converting L-dopa or 5-HTP to dopamine and serotonin. It's mutated, so they produce ADC, which is not functional. As a result of it, they have huge amounts of 3-IMD in their CSF, so it's one of the biomarkers. They do not make any dopamine, therefore HVA, homovalenic acid, is highly reduced. It's almost at zero. So they have tons of L-dopa within the brain and CSF. They cannot convert it to dopamine no HVA. And the same goes for serotonin. 5-HIA, it's almost below limits of detection. So that tells you how severe the disease really is. That combined with the phenotypic presentation and genotypic pretty much confirms the diagnosis. So in our trial, we have these two markers as a biomarkers for us to help us assess the effects of gene therapy. In addition, we do PET scanning. So that would tell us about any possibility of fluorodopa alpha-metatyrosine to be converted by this enzyme to dopamine and incorporated into vesicles. We also perform series of DAT scans just to make sure that the pathway that we are affecting is intact. And in fact, they do not degenerate in terms of the nigrostriatal pathway. It's still there. So the terminals are being present, but they cannot produce and store any dopamine in the vesicles. So in our approach, so just to put it in the context, I've developed 20 years ago gene therapy for Parkinson's disease with AAV AADC. So it's basically the same construct. And there, of course, we've been targeting putamen simply because that's where the dopaminergic receptors are, and the idea behind that trial has been to really improve the responses of levodopa to dopamine in the patients that have degenerated. In this particular case, we've targeted midbrain. We've targeted substantia nigra and ventral tegmental area. So we really wanted to express the AADC in the cell bodies. And then, I'll show you in a minute, we use the axonal projection to really distribute the gene and the vector and the AADC into the terminal areas. So basically we use the brain pathway or the circuitry to help us disseminate the vector. The next target is raphe in the brainstem. This is not shown correctly in this anatomy, but that would be something that we'll be incorporating in the next phase. This is all NIH funded. Columbus Children's Foundation has been really generously helping with this work. So we're trying to take a very careful stepwise approach into this work. So I mentioned to you, in terms of gene therapy and the viral particles, there's a tremendous science behind all of this in terms of tropism, what cell is doing with these particles. We've described something that actually may be of interest to you in terms of thalamocortical projections, so we can target them in monkey brains and basically be able to express gene of interest anywhere in the cortex we'd like to the thalamocortical projection. So, the same idea applied here, where we've delivered the viral vector into the cell bodies. I told you about the ventral tegmental area and substantia nigra. Again, idea being that we want to affect both motor and also non-motor component of the disease. And then we use axonal transport to send it to the terminals, which in this case would be in the striatum, specifically in the putamen, caudate, nucleus accumbens. Some of the work that led into this, there's an administration of the AAV2 vector into the nigra of monkeys on one side, and you can see dramatic axonal transport into the caudate, putamen, septum, accumbens, prefrontal cortex. So this has been done over many, many years to try to understand which pathway we'd like to use and how we'd like to deliver the viral vector. The other thing that works to our advantage, not only that this pathway is preserved, as I told you, the DAT scan clearly shows that the pathway is intact. There's a tremendous collateralization of the neurons in the midbrain that produce dopamine. So this is very well described in terms of the topography, but basically the groups of neurons that are in the midbrain would then project to multiple parts of the projection. This is the striatum. So very important, obviously, to keep that in mind. So that shows some of the work from Matsuda that actually shows that single neuron can provide that much innervation in the projection area. So again, by design, this is the first study ever done that uses prospectively axonal transport to disseminate viral vectors. So we started with those one escalation trial. I told you about biomarkers. Obviously, you're looking at the symptoms, motor function, and then we have number of primary aims. Again, being this is a safety study, we look at the brain MRI, look at adverse events, and then any issues as it relates to the post-gene transfer. We knew from the get-go that because of those patients are so hypersensitive, that we'll be encountering dyskinesias, and that's exactly what happened. Initially in that study, we were looking at 4 to 17 years of age. This is the bracket. Had confirmed ADC deficiency, and all those patients were non-ambulatory, despite the treatment with the anti-Parkinsonian drugs. So as of today, we have 15 subjects who were treated, some of them over 2 years right now. We have 4 dose groups. We started with 3 patients in each, escalating the dose using small volume, and then we escalated in terms of larger volume, and now we're looking at the high volume and high dose. So stepwise approach in terms of trying to build our confidence in terms of the safety, but also efficacy. Here what happens during the infusion, so you can see one of those children. This is the cannula that we've lowered into the substantia nigra. You can see the infusion. So again, we can monitor this in the real time, and we can really assure ourselves, first of all, that we're the right target, and that system that I showed you absolutely assures that. And then we move it a couple of millimeters towards the midline, and this is ventral tegmental area. And again, you can appreciate here, this tremendous precision in terms of being able to keep the vector within the parenchyma. Then we go to the other side, substantia nigra infusion on the left side now, followed by the VTA. With that system, and this is really pretty exhaustive work that went into developing it, we absolutely can control this delivery, and it looks pretty much identical for every single patient. So it's one of the subjects that we've treated. Again, this girl, it's 8 years of age at the time of the surgery. You can hear how she breathes. They have tremendous amount of secretion. They get echologic cry size, so that's very typical. They would get it a few times a week. Completely non-ambulatory, non-verbal. Very, very asocial, incredibly irritable. This is her 5 weeks later when she receives the gene therapy. None of them would have head control, so you can clearly see that this is rapidly coming back. She's becoming dyskinetic right now, which is exactly what we anticipated. And dyskinesias last in those kids up to 6 months. Remarkably, she's regaining movement in her legs as well. Remember, those kids, most of them never move. They don't understand how to ambulate. And this is 6 months later. She's not walking yet, but you can clearly appreciate that her motor and non-motor component of the disease is dramatically improved. They require lots of physiotherapy, of course. Physical therapy simply because for the first time they can respond to that. This is her now at 18 months. She started pretty much walking already with her mother at 9 months. This is her at 24 months when she had her follow-up visit. She can speak around 100 words right now. She's back at school. She sleeps well. Complete transformation in terms of her catching up now with the development which she lost. Here's another patient. I'm not even showing you the best ones. I mean, usually, people like to. But yeah, there's dramatic improvement. Here's another girl, also was treated early on at almost 7 years of age. Cannot pull herself, no head control, very hypotonic. And this is her now 3 months later. So those are parts of the test that we run in terms of evaluation of those kids, in terms of their motor responses. So you can see that now she can hold her head. She cannot, at 8 months she can sit now unassisted. This is now her at 12 months.
Audrey, can you turn around to me? Hi, keep going, keep turning. Come on.
and she's beginning to walk. Assisted, of course, but that obviously it's something that is improving very rapidly. It's quite amazing because those kids rapidly improve and they keep on improving. We only have the follow-up for over 2 years right now with them. So here we have the dyskinesia profile. I'm showing you 6 or 7 subjects here. Again, with that gene expression mounting within pretty much, it's maxed out in terms of the expression levels at 30 days. And then you can see pretty much that within the first month or 2, the dyskinesias will peak. And then as the receptors become less supersensitive, I think there is modulation in the brain that clearly is responsible for them to pretty much become less and less dyskinetic. It's amazing actually that these kids, they seem not to be bothered by dyskinesias so much. I mean, they're not really that bothersome, but obviously that interferes with a lot of their function. Here's the occurrential crises that we have in those kids, with the exception of just one kid, the first one that had a pretty severe mutation. She still has some occurrential crisis, and every single child is gone. It's gone within pretty much a month and a half. They never experience it ever again, which is a huge quality of life change for these patients. Some of the motor functions, so these are measures that are being applied in these children, so you can see that they dramatically improve and they keep improving with time. Obviously, they are not in the normal level of their age bracket, but hopefully they'll be catching up to this. What's quite substantial is that the HV8s dramatically improve. Actually, the last key that we've just measured, it's because we've increased the dose and the volume, it's way within the normal levels at this point. So not only we have a reliable marker of the gene expression, we can also measure the levels of the expression with the biomarker. 5-HIA doesn't get changed, of course, because we have not targeted the RAFA at this point. We only concentrated on the dopaminergic system. So that's important to have. The non-motor component is also dramatically improved. Irritability, it's dramatically improved. They all sleep, so also their parents as well for the first time. In terms of the sweating, the airway obstruction, that's a huge issue for those kids. They develop pneumonia, they aspirate all the time. That's pretty much gone within 3 to 6 months after gene transfer. Some of the other biomarkers, this is PET scanning. So that shows you the midbrain of one of those patients at baseline. This is during the surgery. So again, I showed you the movies. This is in the axial plane. This is how it looks like. You can see absolutely no signal here in the midbrain. And then after gene therapy, you see dramatic presence of the gene expression. Again, this is exactly how we planned that. And you can see that it's completely identical to our gadolinium signal, which we knew because we've studied it very carefully just to make sure that we understand the distribution pattern. What's even more important in this approach is that, remember I told you about this axonal transport, shows you one of those monkeys that we've treated with this particular vector. And there's something magical about this particular vector because of the purification way how it was constructed. It's exclusively neuronal, exclusively anterogradely transported, which is critical for this and our other studies as well. But this is the pathway that we are affecting, right? So we go into substantia nigra, and obviously it's not reticulata and compacta. We cannot distinguish between them, but a lot of transduction is in the reticulata and the VTA. And then we're using the nigrostriatal pathway to distribute the AADC into the terminals. And that's exactly what we're seeing on the PET. You can see the caudate and putamen in one of those patients before gene transfer. This is the administration within the midbrain. You can see tremendous increase of the signal both in the caudate and the putamen prefrontal cortex as well. So we're really affecting the whole circuitry that we've targeted through the axonal projection. As I told you, we started this at UCSF. Now, I'm also, in addition to being at UCSF, I'm also at Ohio State university where we've opened another site, and I have the third site in Warsaw. We have our own gene therapy center, and we started treating European patients, but also patients from Canada now, and Israel, from many other countries. And this really is driven by parents and the advocacy groups. Those parents, this is not a huge indication, it's only maybe 120 some of those patients around the world. So we're trying to really help them as well. We've made a number of changes in the procedure right now. Instead of 4 infusions, we only do 2. This is the system we invented, a very simplified one, much easier to use. It's called the ball joint array. Allows us to cut surgery time from 8 hours to 3 to 4. I mean, it's dramatically faster, much safer for those patients. This is one of those subjects. A few days after the surgery, there were 2 patients in Poland. We've treated them both. In terms of the coverage, it's really phenomenal. Since I'm in Spain, this is the first Spanish girl, Irai. So that's her 2 days after surgery. And you can see hypotonia. You see no head control whatsoever in this kid. And this is pretty sweet. So the quality of life for all of them, it's quite striking. And that's not even 6 months, this is 4 months later. And you can see the motor control, you can see the balance, you can see the head. I mean, those are things which those kids would never be able to demonstrate. I don't have the latest video, but she's already grasping things. So these are parents. I don't understand what they're saying, but probably something good. This is the UK girl, just treated on Tuesday. This is her day after the surgery. These are the parents with the siblings. So, it brings us tremendous joy. The foundation is helping us pay for these patients, raise some money. We absolutely charge them nothing. We really want to help those kids as much as possible, and we are of the opinion that for those orphan designation disorders, we'd like to do it for free. We'd like to create foundations. We just like to give it to the patients and the families. We don't want really to make any product out of it, because I don't think that's right. So anyway, the conclusion, I got a lot of pushback from a lot of pediatric neurologists that I'm going to be sticking needles in sick children's midbrains, and it took us, I would say, 15 years to really get this thing right. It's a scary thing to do. What I'm not telling you about, because I also developed a number of approaches for diffuse pontine glioblastomas, so we've done a lot of infusions into the pons of those children. So we had the technology, know how to use this infusion system in that particular condition. So I'm here to tell you it's safe. I mean, I'm going to knock here, obviously, but so far it's incredible. I mean, this technology, with being able to avoid the blood vessels, see every single vessel along the way, being able to change the trajectory of brain shapes. I mean, this really provides a tremendous safety. I think for those that will tell you for epilepsy surgery or anything like this that they want to do it without MR guiding, I would be really careful. You just can't do these things. I mean, maybe it was fine in the 70s, but right now the technology is here to allow neurosurgeon to be absolutely certain of where that needle is going to go. I mean, this technology is here and it's here to stay. So I think that's absolutely essential. I think without this, I think that would never be safe and efficacious. And I think we're happy to see that getting this ADC activity up and running is exactly what we were hoping to see. I told you about the 3 sites. The one in Warsaw, it's designed and staffed in a way that we can actually probably do around 8 cases a month. So we can probably do 2 patients now a week, because we have all this technology now that really allows us to move quickly. And we keep adding things. I didn't get into details, but trying to use larger volumes so you can do faster infusions and be able to get this thing safely into those kids, and then be able to obviously try to bring the kids we've treated already and treat their brainstem and try to get serotonin going, because we don't know what it really does. I mean, for some of you, if you're neurophysiologists or are interested in neuroanatomy, things that we are seeing in the absence of serotonin in the human brain is unbelievable. Because again, they have no serotonin. But things that we thought that serotonin is driving, now seeing dopamine doing it, I mean, it's very confusing. That I think, we thought at the beginning that only maybe 5, 6, 7-year-olds will respond. Absolutely not true. We've treated 27-year-old men and 18-year-old girl from Israel. We've treated 13-year-old boy. They're all responding. It's unbelievable. I mean, that brain plasticity, I think it's really something we have to rethink a little bit in terms of the age, because this really allows us to ask those very critical questions. So, again, Javier, thank you, and the whole foundation for making tremendous effort supporting some of those cases in Europe, and we really like to create a partnership between OSU right now and the Columbus Children Foundation, maybe other foundations, to really be able to raise enough money so we can really bring those kids in the States and here in Europe and really at least give them some quality of life and be able to move it forward. I mean, this is truly international, huge effort. I published in year 2000 that I'd like to do it in those kids. It took almost 20 years to get there. And I'm glad we took our time, because had we done it 20 years ago with the version 1.0, I think that would not be looking as good as it is now. Nalin, it's another neurosurgeon that at UCSF. Jill is the study coordinator. Waldy has been there from the beginning, and so not going to go through all the names, but those are the people in the clinical team at UCSF. We work with number of Keith Highland is the guy that actually came up with the ADC mutation, so he was the one that first described. He runs the labs that actually do all the analysis for all the samples. General Hospital of Philadelphia, I got multiple NIH grants. They had a core facility. They made the vector for this program, and that really, they deserve tremendous credit for that. That vector was made over 10 years ago, and it's still working fine. So that's quite amazing. Just to put it in context, one campaign of this vector would be enough for all the children around the world for 10 years, the way that we're giving it. So, I mean, yes, it is maybe more expensive and more troubling in terms of doing intraparenchymal administration, but once you get it right, I think the cost of goods is almost nothing. It's just like in a surgical approach. Now at Ohio State, Russ, Lonzer, Jeff, they're both neurosurgeons there as well. Amy's the study coordinator. Toni Pearson's been working with me from the beginning. She trained with Daryl DeVivo in Columbia. She's a neurologist, pediatric neurologist in WashU with her team. Manju Kurlan and Simon Hales, they're in the University of College of London. So again, some of the patients that we're operating right now, they've been following since they were little babies. So obviously this is a huge thing for them as well. Maria Roser Pons, she also trained with Daryl. She's in the University of Athens. And then Angela's, she actually is the neurologist that follows Irai. So this is the Spanish girl that I showed you. She's tremendous. She's in Children's Hospital in Barcelona. Really very highly engaged in the work as well. The group that I put together in Warsaw, I mean, tremendous. Mirek, it's the chair right there. We co-directing the whole center. These are all neurosurgeons and anesthesiologists. I mean, the team is growing very rapidly. Those kids are really frail. The recovery can be quite challenging. So we have PACUs and specialized teams able to work with them. Advisory board. So you may recognize some of those names. And of course, Javier and the whole team here. Thank you again for. And I think you hear directly from the parents and how grateful they really are. So as I said, this is mostly driven by NIH for many years now. ADC Trust and Pediatric Neurotransmitter Deficiency. Those are two foundations. ADC Trust in the UK. It's really the one that is driving a lot of it as well. I told you about these two institutions. So I think I'm not going to tell you about Parkinson's. I don't want to bore you too much. I think one disease at a time, so hopefully you'll bring me here again. So thank you very much.